Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the anatomy of supracondylar fracture. What is a supracondylar fracture? The supracondylar fracture is a transverse fracture of the distal part of the shaft of the humerus near the supracondylar ridges. Two types of supracondylar fracture: extensor type, the most common, and flexion type. Supracondylar fracture is common in young ages, maybe at the age of 5 to 12, and more common among the boys because they are more prone to have injury. But it happens both boys and girls. It may happen at any age. It is produced by fall on the outstretched hand or fall onto the elbow. The lower fragment is displaced posteriorly in most cases. There will be swelling and ecchymosis at the fracture site. The triangular outline among the medial epicondyle, lateral epicondyle, and the tip of the olecranon process is lost. The distal fragment and soft tissue pull backward by the action of the triceps brachii. The brachial artery is bowstringed over the irregular proximal fragments of the humerus. Okay, so that is the problem because the bony part are broken, transversely fractured, and these edges are sharp, so blood vessel may be damaged, the brachial artery that divides into ulnar artery, radial artery, so the blood flow to the forearm may be compromised or lost. Tenderness and edema over the fracture site, like any other fracture. Okay, this is the clinical feature and pathogenesis. Range of motion, elbow is compromised because of the supracondylar fracture. Tenderness when palpating over the tendons of the extensor carpi radialis brevis and longus. Well, so idea is that the nerve, any nerve at the fracture site may be damaged. It may be posterior interosseous nerve, it may be the median nerve, most common the anterior maybe anterior interosseous nerve, maybe even the ulnar nerve. Any nerve may be damaged. So if there is damage to the nerve and there is fracture and there is edema at the site of injury, ecchymosis, we may have tendon onto the muscles. We have pain on the tendons of the muscle, like extensor carpi radialis brevis and longus, brachioradialis tendon, flexor carpi radialis, flexor carpi ulnaris, pronator teres, palmaris longus. All the tendons may have tenderness because of the fracture site, tissue damage, swelling, edema, and ecchymosis. Ischemia, that is lack of blood supply, and loss of action of the muscles of the forearm lead to Volkmann ischemic contracture because of lack of blood supply. Okay, and also loss of action of muscle that will lead to Volkmann ischemic contracture. Okay, this is the image, the X-ray of the supracondylar fracture. This is the humerus, radius, ulna, part of the olecranon process, lower separated piece here of the humerus. Okay, so this is the supracondylar fracture. Just at the supracondylar ridge area, there is fracture. Okay, so this is the fracture, transverse type of fracture at the distal part of the shaft of the humerus. This is a classification, Gartland classification. Type 1, bones are not separated, just a transverse fracture. Type 2, partly separated. Type 3, fully separated like this. Okay, and this needs surgery, exploration to re-establish the blood supply and nerve supply, or to repair the blood supply and nerve supply. Okay, so this image has been taken from Gray's Anatomy from 41st edition. Deepening of a lesion, a median nerve extricated, that is, it is removed from compression from a supracondylar fracture. 9-year-old girl, 3 days after injury, there was complete recovery, but it should be done very quickly. Okay, within few days, maybe within few hours, any damage or compromise of the nerve. A median nerve extricated, that is removed or separated from supracondylar fracture in a 13-year-old girl 8 weeks after injury. There was no recovery that is possible. So supracondylar fracture is a relatively devastating condition. It should be managed by the orthopedic surgeon, neurosurgeon in a hospital setting. If the nerves are compromised, nerves should be extricated or removed from the adhesion compression. Okay, another image here, Boxman ischemic contracture. What happened? Boxman ischemic contracture. Okay, ulnar nerve is exposed during flexor muscle slide 8 weeks after supracondylar fracture. Okay, the epineural vessel and also the ulnar recurrent collateral vessels are occluded. Okay. Okay, so what happened? The nerve is compressed by the swollen infracted muscle. Appearance of the hand 14 years later. Look at that, muscles are atrophied, damaged in Boxman ischemic contracture, and nerve supply also compromised in many cases. Okay, so there may be like a claw hand appearance, look like that of the ulnar nerve injury. The type feature happened in case of this Boxman ischemic contracture. Okay, ulnar nerve supplies the interosseous muscle, intensive muscles of the hand, the medial to tendon of the flexor digitorum profundus. So all may be damaged or lost. The function will be in jeopardy. There will be Boxman ischemic contracture. So ischemic contracture, the heaven will get muscle atrophy. This is the outcome of or complication of supracondylar fracture. Complication of supracondylar fracture, any nerve may be damaged. More common median nerve injury, but ulnar nerve injury is also possible. Even branches of radial nerve, posterior interosseous nerve may be damaged. Brachial artery may be damaged if it is near the fracture line, the sharp edge of the bone. Damage to anterior interosseous nerve, compartment syndrome. There may be collection of fluid in the anterior compartment of the forearm. So a lot of surgeons make a longitudinal incision to free that compartment from the over collection of the fluid. Boxman ischemic contracture, as we have seen, claw hand if ulnar nerve is damaged. Myositis ossificans, there will be calcium formation in the muscular spaces also in the muscles. Cubitus varus is common complication after supracondylar fracture. Deformity and loss of range of motion like any other fracture. Treatment should be done in a hospital setting. It is a relatively devastating injury. It may be unilateral, may be bilateral. It needs immediate hospitalization. It should be managed by an orthopedic surgeon who is expert in this area. and neurologic consultation, and even the vascular surgeon consultation, percutaneous pinning and immobilization when there is no vascular or nerve damage or compression. Manage conservatively without big surgery, but we need surgery in most of the cases because of the damage inside, and to prevent damage in the nerve and arteries, we need open surgery in many cases. And that's all about the anatomy of the supracondylar fracture. If you have any question, please feel free to ask me. Please share the information with your friends. And please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.